All right, we got people joining us now. We'll give them a few minutes to get started and then we'll kick it off. So welcome everybody. If you want to put in the chat box where you're from, that would be a great way to get started today. We've got 50, 60 people in the room, up to 70. So we'll give everyone another minute. Denise is from California, Stephen from Michigan, Claire is in Philadelphia, Al's from California, we got Portland, California, all over the place. Massachusetts, Brooklyn, all right. Texas, Boston, okay. Switzerland, all right, we're international. All right, we got 90 people here. We'll give another 30 seconds and then get started. All right, Denise, yes, this will be recorded and we will share the recording after we are finished. It'll be posted on YouTube and our website and you'll get an email with a link. Okay, we are up to 100 people. I think that is a good time to get started. So I'm going to stop sharing my screen. And then, all right, my talking points. So welcome everybody to our webinar today. Just a few table setting matters before we get started. We do have captions enabled and yes, this will be recorded. So if you need to enable the captions, you can click the button on the bottom of your toolbar and that will enable them. And thank you for joining our webinar titled Long COVID and Disability. We're very excited to share some learnings on this important topic with you. So my name is Andrew Wylam, and I'm the president and co-founder of Pandemic Patients. If you are new to Pandemic Patients, we are a 501c3 organization dedicated to relieving the harm caused by COVID-19 and helping people affected by the coronavirus pandemic secure the services and support they need to live their best lives. To get a copy of the recording after today's webinar, you'll get an email to your inbox, and it will also be posted on our website and our social media channels, including YouTube. And we are hosting today's webinar in recognition of International Long COVID Awareness Day, which is a community-led event designed to call attention to the need for more awareness, education, advocacy, and resources for people affected by long COVID. We hope our webinar today will help empower people with long COVID and build momentum towards a future where people with COVID-induced disability are able to thrive. And did you know, according to the most recent data released by the US Census Bureau, approximately 6.8% of Americans are currently experiencing long-term COVID-19 symptoms. This means over 22 million of our fellow Americans are currently experiencing long COVID. Among those, 78% are experiencing activity limitations, and 21.8% would categorize those activity limitations as significant. So these sobering statistics are an important reminder of why the issue of disability is so important in the context of long COVID. So I will be serving as your moderator today, and I'm very pleased to introduce our panelists who bring valuable expertise from the legal, medical, and patient perspectives. So first we have Dr. Jackson. He's a renowned expert on long COVID and its impact on cognitive and mental health functions. He currently works as a director of behavioral health with the Vanderbilt University Medical Center's Critical Illness, Brain Dysfunction, and Survivorship Center. Next, we have Dr. Malcolm, who is an internal medicine physician, currently working as the medical director of Rhythm, a long COVID clinic. He has treated long COVID patients for several years and has several important insights regarding this condition. We also have with us Victoria Williamson, who is a civil rights attorney with bountiful experience representing vulnerable and underserved populations. Vicki recently joined Pandemic Patients as a staff attorney, where she helps patients overcome challenges related to disability and employment. Ty Godwin is a long COVID patient and a member of the Pandemic Patients Board of Directors. Ty's background is in software sales in the telecommunications industry, and he has worked to raise awareness about long COVID since first being exposed to the coronavirus in 2020. So again, the Q&A feature is enabled. So if you have a question for our panelists during today's discussion, please submit that using the Q&A box instead of putting it in the chat box. So we're going to get started with our conversation today with kind of a broad question that might have some varying responses. And that is, when someone is disabled by long COVID, what does that mean? And I'd like to start with Ty to give the patient perspective on what that means to him.
Yeah, thanks, Andrew. That could be a long answer. In that it affects virtually every system of the body. It can look different in patient to patient, but it's a disease that does not discern what system of the body that it does attack or impact. In my case, that's everything from vasculitis, neuropathy, mitochondria damage, endothelial damage, blood clots, and underwent IVIG infusions for a broken immune system. Unfortunately, that has led to stage 4 cancer. So I've got a lot on my plate.
Definitely. Thank you for sharing that, Kai. And next, let's hear some medical perspectives on this topic. Dr. Jackson, what does it mean when you hear someone is disabled by long COVID?
Well, I think we have a lot of simplistic, if you will, ideas about what disability is. I think too often we think that disability is only the person sitting in the wheelchair, perhaps at the VA hospital, who someone is having to push up a ramp. I think the truth is there are nuances when it comes to conversations about disability that we need to recognize, and that is there are vast numbers of people, I think, who are quite disabled, and if you interacted with them, they wouldn't necessarily look that way. If you talked to them, they wouldn't necessarily sound that way, but regardless, they're functioning at a level far below where they were before. We can quibble about technical definitions of disability. I know those exist legally, for instance, but it's a practical matter. People are disabled when, to me, they are meaningfully limited by the effects of their illness such that they can't do the things they did before with the same faculty they had before. That's the definition of disability that I use. And again, highlighting that many people with long COVID, they don't really look disabled. And that's part of the challenge,
Yeah, I think that's a very helpful way to think about this. So Dr. Malcolm, what does it mean to you?
It's a tough question. And I think what I want to add, like in terms of like the medicine behind this, is the unfortunate kind of like joke that patients will tell me is, I go to my doctor and they run a whole bunch of tests and they can't find anything abnormal. Good news, there's nothing wrong with you. And the perspective that I've had over the last 4 years of seeing this illness is to believe my patient that something happened. And we all know that this is what happens with infection, and COVID being the most, 1 in a million, year virus, that something would happen. So, I can bring up some examples. So, patients of mine, some of them come in with extreme chest pain and shortness of breath. And we do chest x-rays, we do CT scans, we do MRIs, we do echocardiograms, we do a whole bunch of tests, and we can't find the answer. And then lo and behold, we come out with the xenon imaging and the XV imaging that's saying there is something wrong. And we look at brain fog, we do scans of the brain, CTs, MRIs, nothing's wrong. Then you look in the papers in the last year, there are papers coming out. There's profound abnormalities with these tests. So what I want every patient to hear and every clinician to hear is, what was it like 100 years ago when we didn't have all the tests that we have to diagnose diabetes and congestive heart failure and multiple sclerosis? We invented them. And long COVID has just really made us all confused because we all thought we knew what was going on in 2020, that we had all these powerful tools. But there are scientists out there now, and they're developing these techniques, and they're showing that there is something going on. So that's really where I get to the disability is the patient needs to, they know in their heart, like, and I think if you have a good doctor or clinician that is believing you, be like, yeah, we're just behind, and like, can I find you the test that really proves, and unfortunately, what I mean by prove, I mean to your insurance company or to like a disability lawyer that like something's going on, because it's out there. It's just really our inability to find it for everyone.
Absolutely. So next, I'm going to turn to Vicky to perhaps complicate this discussion a little bit. So what can you tell us about how this concept works in the law?
So yes, it'll complicate things a little bit. I have a background in employment discrimination, essentially. And so when I am looking at whether an individual is disabled, I'm typically looking at the definition under the Americans with Disabilities Act. The Americans with Disabilities Act essentially says that a person is considered disabled if they have a mental or physical impairment that substantially limits one or more major life activities. The courts across the country have considered that definition from a very broad perspective. And so typically, we don't necessarily have to have, as lawyers, we don't necessarily have to have a specific diagnosis, but we can take symptoms that people are experiencing that limit one of their major life activities and apply the Americans with Disabilities Act to consider them a person who is qualified with a disability. That's just, again, with respect to the Americans with Disabilities Act. There are other varying factors that come into play when people are dealing with long COVID, when they're dealing with insurance companies that might have a tweaked version of what disability means, but generally that's what we're looking at.
Thank you. So my next question is for the medical professionals here. In your experience, what types of long COVID symptoms do you see that are commonly disabling for patients, and how do those symptoms interfere with their lives?
It's a good question, if I may. I'm a neuropsychologist and I work in the cognitive space primarily. So I don't see people with a full spectrum of symptoms that Dr. Malcolm likely does. But in the context of many patients I see, cognitive impairment is probably the main thing that they complain of. We use the term brain fog, and I think we use it carefully. Some patients don't mind the term. Most of the patients that I interact with don't particularly love the term, but whatever we call it, it's a real phenomenon that impacts people. If you ask patients, many of them, this is true long before the pandemic, if you ask patients, what is the ability that is the most important for you to preserve? That is, what is the ability that would be the most problematic if you lost it? A majority of people would say cognition. I value my brain because if my brain is intact, I can deal with a lot. But if my brain is not intact, I'm not sure that I want to deal with a lot. That's what we hear from patients. And so often as we see the cognition eroded in these patients, we see subsequent symptoms of depression, we see symptoms of anxiety, we see symptoms of PTSD, and why wouldn't we? Because as their cognition goes, so goes their life very often. Day-to-day challenges that our cognitively impaired patients have include simple things, complicated things, driving, cooking, remembering to turn the stove off, having a problem managing your money, having difficulty balancing the 15 medications you're now taking when you took absolutely none before. These are executive function abilities. Often they're quite impaired. These are the sorts of things we see. I prefer often to use the term brain injury to brain fog. I think it's a little more accurate. Not everyone with long COVID with cognitive complaints has a brain injury, certainly not, but many people do. And I think we should probably call it what it is, and that is, for many, it's a brain injury.
Certainly, and that does come up quite frequently in the legal context because something like brain fog, when you use that term, it's very nebulous. It can mean a lot of things, and it's hard to diagnose. It's hard to objectively say what that means for how that impairs a person's ability to work. And so we have found much more success in using terms like cognitive impairment or brain injury to establish those limitations because they're more specific. So turning to you, Dr. Malcolm, what are your thoughts on this?
Yeah, so just to jump up what Dr. Jackson said, which is brain fog. And one thing that I did want to comment on, and just like I will maybe drop in some clinical pearls, which is the medical term we say of like things to remember as a doctor or whatever as a patient, is how do I even document that? You know, like we have this thing called ICD-10 codes, which are codes that we have all recognized to say this what's going on. There's no ICD-10 code for brain fog. You know, we have mild cognitive dysfunction. Like, what does that mean? What's mild or moderate? You know, U09.9, which came out in October of 2021, I think. You know, I remember I was the guy at my old clinic being like, it's finally out. Like, we're finally recognizing this as an illness. So I think one thing to the patients out there is when you're seeing a clinician just being like, hey, could you make sure you are documenting that I have this, that I just don't have fatigue, that I have this, that I have long COVID, that I have ME/CFS. So one long, so brain fog and all of kind of the things that entail behind that. Fatigue is huge. And so what I mean by that is like baseline fatigue, like I can't get out of bed or I'm just, I have fatigue, you know, at baseline. So you can't really even get things done. Post-exertional malaise, and so just like a little bit of explanation of that is any all the patients in the room are like, duh, I know what that is. Where you are exert yourself mentally, emotionally, physically, and then you pay for it a couple hours later, a couple days later. And that really has to do with a fundamental issue with how the mitochondria are working, how we're processing energy molecules. So that can be extremely disabling. POTS, which is kind of postural orthostatic tachycardic syndrome, which has many different flavors to it. So some of my patients are like, Dr. Malcolm, I can't sit up in bed. I have to lay down. And that is so hard, going from someone who was just running marathons to now they can't even sit up in bed to knit or type or do anything. Other people, it's just standing up. Hey, I can't walk around as much as I can. I have a patient, for example, who, you know, can do a certain amount of work, but then the heart rate spikes so much, up to 160. That can be very disabling. I definitely also have another subset of patients that have chest pain and shortness of breath. And that can be really, really hard on people where they're constantly feeling air hunger. The neuropathy is really bad. I have so much pain that I can't move around. I'm in I can't live my life. So long COVID has more than 200 different symptoms. It really is everything. And so I've only mentioned like a snippet, and I know there are people out there being like, what about this? What about that? Yes, there are so many things there, and I'm not doing it enough of a service because there's definitely things I've missed.
Well, thank you for sharing all that. I'm interested in getting more of Ty's perspective on this as a patient. So, Ty, could you share what some of your most disabling symptoms have been and what your experience has been like with that?
Yeah, it's far-reaching. The cognitive piece, I think the one thing that put my Social Security disability application into approval status is I went in for what wound up being 4 hours of torture, which was largely a Pearson's cognitive test. And I knew, and I was having a bad day, and we talk about spoons in the long COVID world of available, spoons of energy. And I could tell by the end, my eyes were glossed over and I couldn't do basic recall of a simple story. Yesterday, I had to Google how to spell the word tomorrow. I used to be, amazing with finance in Excel. And I just make common mistakes. So the cognitive piece is a huge one. The other for me in my line of work, I traveled globally, and I would often be go from Mountain Time Zone to East Coast Time Zone. I'd have a dinner that night. I'd have a breakfast before a day full of meetings. I can't imagine even trying to tackle, a half a day of that activity, because there's this post-exertion malaise that the doctors will talk about, where you do overextend yourself and it'll send you to the couch or the sofa. So not to mention, the clinical things like neuropathy that keep me up at night. I'll take ice cold baths just to try and calm that down to get to sleep. So I will sleep in until 10 o'clock. So I joke, it's not a joke, that if you want to hire someone that can't tell you how often they can come into work, what days they can come into work, but maybe on a good day, okay, I'll show up at 10 or 11. I'll have to leave early. I'll make a ton of mistakes, and I'll probably have to call in sick the next couple of days. Then I'm your candidate. Then I'm your employee. So it's crippling in many ways. So hopefully that answers.
So with some of these things in mind, I'd like to turn to Vicky next. What kind of legal issues do people encounter when they're experiencing symptoms like these?
So a lot of times I have, when people come to me and they have, whether it's diagnosed as long COVID or whether it hasn't been diagnosed, they come with these debilitating symptoms. And they start off in a situation where they think, how will I continue to do my job because I can't function? My brain has been impaired. It's hard for me to even remember coming to a meeting with you, these kinds of things. And we first talk about getting reasonable accommodations to see if that's a possibility that will help them be able to maintain their employment. So I work with clients and potential clients to explain to them how to obtain a reasonable accommodation from their employer. If it's gotten to the point where they need to take a medical leave of absence from their job, then I can work with them to try and obtain job protected leave under the Family Medical Leave Act, which typically involves the patient and the lawyer working with the doctor to try and get a certification so that they can take an extended period of leave. And again, that leave is incredibly important because it's job protected. And that's just the federal law. Many states have their own family medical leave laws that have better categories that don't require you to have worked at a place for 12 months, and it's paid leave versus unpaid, because the federal law only allows 12 weeks of unpaid leave within a 12-month period after you've been working somewhere for a year. But again, depending on where you are, many states have a variation of that are more employee friendly. And then when you get to a situation where you've taken all of your medical leave, you're still not feeling better, you're not sure whether you can continue working, there are options of applying for short-term disability, long-term disability, again, still continuing reasonable accommodations from your job, which includes leave, and then ultimately getting into the Social Security disability arena. So there's sort of a series of events that you can go through once you realize that you start suffering from disabling conditions. But the recommendation is that you would contact an attorney sort of right away. You contact us and we can either help you or get you in touch with someone that can help you. And that we would work hand in hand sort of with your medical providers to make sure that your records say what they need to say in order for you to be able to be qualified as disabled.
That's great. And we've got one question from our audience. Does FMLA require a company to be of a certain size?
Yes. So again, the Family Medical Leave Act in the federal says that the company has to have at least 25 employees or more, but there are state laws that eliminate that requirement. So you definitely want to check your particular state as to whether or not their civil rights or employee protection laws will get rid of that that particular limitation, along with the requirement that you be working for 12 months, because some states get rid of that as well. But that's something that we can help you kind of sort through. Again, when people have cognitive impairments, sometimes it's difficult for them to research. And so it's easier to reach out and ask for assistance, so we can help you through that.
And FMLA is certainly a very, very important protection for employees. It has come into play in a lot of the cases that we worked on. So it's a good thing to be aware of and understand how to use that benefit if you need to. So our next question is kind of for everyone, and it's a little broad, but with these symptoms in mind, with this kind of disability in mind, what can you describe how patients have barriers between them and their ability to access the resources that they need? Ty, can you speak to that at all?
Barriers on, sorry, I was
Yeah.
answering a chat. I'm demonstrating brain fog real time here.
So I've heard quite frequently that a person's cognitive impairment can make it harder for them to apply for disability or get connected with the resources that they need. Has that been something that you've experienced?
Indeed. I mean, I've got a great wife and life partner that I can't imagine navigating this labyrinth without her either fully, taking ownership of paperwork, but certainly being a constant consigliere, if you will, in that whole process. Because I'm constantly having to check with her that, hey, did I fill this out right? Or how would you answer this? So yeah, it's a challenge, most definitely.
Yeah,
So what do you see in this arena?
Yeah, well, I would just second that, Ty. I think very often people don't know what they don't know. It's true for all of us. I don't know what I don't know, right? We don't know what we don't know. And if you've never had to advocate for disability before, I think it's not surprising that you have no idea how to do it. You've very likely never heard of ERISA. You can't even spell it, right? That's the long-term disability rubric that is available. I didn't know what ERISA was, right? I know what it is now because on almost a weekly basis, I'm helping patients pursue long-term disability through ERISA. So I think the term labyrinth, and the challenge here is that our long COVID patients, often now cognitively impaired, have to be at their absolute sharpest to figure out how to fill out applications, which often are kickback because they're not filled out correctly. Even as a psychologist who's filled out hundreds, if not thousands, of disability applications, I don't always know what they're asking for. They differ tremendously by company, by state. So I think it's really complicated. Recently, I made a comment in a public forum about people needing to add an attorney to their healthcare team. And someone said, I think innocently, well, why on earth would you do that? And to me, I think it's really crucially important. Not many of us have our own attorney at the ready. We don't necessarily have an attorney who lives across the street, that we can have a beer with around the grill and ask advice about disability. But trying to find an attorney or some legal guidance, I think, is important. There's not much more important than that. That is one of the key boxes, I think, that needs to be checked early in the process if you're going to advocate effectively. You need an attorney. You need some legal support.
Mm-hmm. Absolutely. I think we can definitely speak to that. But before I turn that to Vicky, I'd like to get Dr. Malcolm's perspectives on this.
Yeah, I think it's hard because in medicine, we kind of talk about like a team. Like I'm here, I'm giving my medical opinion on like what we should do. And here are the action items. And the action items are get an MRI of your head and get an echocardiogram, an ultrasound of your heart, and start this medicine. And we kind of say like, hey, you've got to fulfill your goal. But what if you're laying in bed and you need to go get an MRI? Okay, well, where can you get that? Okay, like, can you get the energy to do that? Where will your insurance cover this? You know, so that might be different. I want blood tests. Okay, well, are you going to walk into your primary care doctor's office and is your doctor going to agree with what I order because I don't have control of what they do? You walk into like another like big corporation like LabCorp or Quest. Could you get a mobile phlebotomist? That costs money. So every step along the way, there's just hurdles to figure out like what's going on. And those hurdles, unfortunately, have a lot of time and money associated with them. And then we add in the brain fog and the fatigue and the inability to stand upright. And we're in a perfect storm of why this is so impossible. So I guess I just want to say is I've changed my practice in ways where I try to walk my patients through like, this is the to-do list. Like, what do you think you're able to accomplish the next time I see you? Who's on your team? And, you know, I'm seeing some of these kind of comments here, like, I'm single, I don't actually have someone, or I was so independent before I didn't need that. Everyone's case is a little bit different. And I will have patients of mine where they've got their team, they've got their, you know, their best friend and their mom and their sibling or whatever. And each kind of member of the team needs to help a little bit of like accomplishing this task. This is why this is so hard. Like if we all were just so able-bodied and we were just like, let's get this thing done, like you would have the effort and the ability to do it, but we're not. We're really disabled in our ability to accomplish it. So for me, it's coming forward to like your doctor or clinician and just being like, okay, I've got my team. This is what's gonna, you know, be the people who are enable me to do this because my brain fog's too bad. Like you need to write all this out and step by step. So it's really just it's logistics. Like it's a lot of that. The medicine is so complicated. That's where I spend most of my life now is trying to figure out this illness. But if I had the answer, but I couldn't deliver it, then no one's going to get better. So yeah, that's really my advice to patients is try to find those people, try to find backups, try to make sure that everything is very, very clear. Know there are pitfalls because unfortunately your insurance company doesn't want to pay for your MRI, and it's going to take weeks for something to be done. The last thing that I do want to say about FMLA and SSDI and like kind of the paperwork is I'll get a piece of paperwork and I tell my patients like I'm going to do everything possible to help you. Like you're sick. I want you to do this, but they'll fax it. You know, medicine still runs on faxes, and it'll come in and it'll be late or it'll be lost in the ether somewhere. And I would have patients be like, didn't you fill that form out for me? And I'll be like, no, I didn't even see it. Or it got missed somewhere. And so oftentimes I'll tell my patients, hey, all right, we're going to do this. Send me a message, bug me in a week if you haven't heard from me, because I've got 100 other things trying to battle this complex disease. I want to do everything possible to help you, but errors happen and we all just kind of need to be on the same page to get the final answer done.
Absolutely. So Vicky, what can you share on this topic? You know, when someone doesn't get the help that they need, maybe from a lawyer or another professional, like what does that do? Like, does that put them at risk of losing some benefits they might be entitled to?
Yes, that's the clear answer. I think it's when you are realizing that you're starting to have disabling symptoms, you want to reach out, obviously not just to your medical provider, because I hope that you're doing that, but you want to try and find an advocate. An organization like this is wonderful because it allows people to contact us. And I get questions all the time, which are just, what do I do? What do I need to do? We like those questions so that we can start from the ground up and trying to provide you with a guided path as to what you need to do. It's incredibly crucial, just like Dr. Malcolm was saying, when you start filling out forms for FMLA, they sort of look like they're simple and that it's just going to be a quick hand it over to your doctor and your doctor is going to sign something and send it right back. A lot of companies have a third party that manages their FMLA paperwork or their disability paperwork. Those two hands don't often, or they don't speak to each other. And then all of a sudden you are terminated because paperwork didn't get sent where it was supposed to get sent. So when you have an advocate who steps in to make sure that that doesn't happen, it kind of starts to eliminate some of the stressors as best we can. And put the focus back on recovery and getting better as opposed to dealing with all the paperwork. So that's genuinely why it's incredibly important to have an advocate from the start if you can. Of course, an advocate can jump in at any point, but it's, just contact an advocacy organization as quickly as you can so that you can have someone in your back corner who is helping through this lengthy process.
And I think
That's great.
I think if I may, sometimes what we've seen is that if that advocate helps you think through issues, sometimes the step that precedes disability is accommodations. And we have certainly seen situations, many of them, where when our patients get the right accommodations, they can manage to do quite well, and in some cases, even thrive. So, this is a complicated conversation. It's not at all a binary all or nothing conversation. Disability is one route. As someone in the chat noted, it isn't a great route. Often it is exactly the right route, but another route that can help empower at times is really thoughtful accommodations. We've seen this with college students with long COVID. We've seen this with people with fairly narrow and specific long COVID symptoms, where if they get the support they need in the workplace, they're able to maximize the abilities they still have and often have quite a lovely outcome. So that's another thing to think about, accommodations.
Absolutely. Go ahead, Vicki.
I was just going to add in that you're absolutely right. It's incredibly important. And it's something that most people aren't aware that they can ask for accommodations, or if their employer doesn't provide the exact accommodation that they've requested, they sort of walk away from the conversation. And that doesn't have to be the case. If you have an advocate in your corner to help try and obtain an accommodation that will work for you, again, it can help in that recovery period, because if you are someone who does better when you're actually able to work a little bit, and it's going to help you mentally recover, it would be incredibly beneficial for you to be able to have a reasonable accommodation, let's say of a flexible work schedule or a reduced work schedule, things like that lawyers are typically able to help get for you. So working in conjunction with your medical provider.
Yeah.
So
Definitely agree. So Dr. Jackson, I wanted to follow up on one of the points you made earlier about how hard it can be for long COVID patients to obtain disability benefits specifically. What advice could you give to patients for how to document their symptoms most effectively when they have to provide that to the insurer?
I think there are a couple things that are critical. I think to document them as objectively as possible is important. And I think it's quite appropriate, by the way, and this can be burdensome, and I admit it, but I think it's quite appropriate for long COVID patients to say to their providers, I'm seeing you today, you're writing a note. Can you make sure you're writing this note in a way that when my insurance company reads it, they will conclude that it is quite objective. If you're giving me a test, can you write a score, right? If you're giving me a mental state exam that broadly characterizes my cognitive ability, can you describe it precisely? When I get feedback from insurers, when I have these, to me, dreaded peer-to-peer conversations with long-term disability physicians who I find are very challenging to work with, the more specific we can be with them, the better. The more objective information we can provide, the better. So that, I think, is the key. And I think there may be other things that are important, but that is perhaps the most specific, detailed data, numerical if possible, that cannot be disputed or quibbled with. I think that's really important. And most providers are happy, I think, to provide that. That may not be at the top of their mind, but the more specific, the better.
Definitely.
Yeah, I'm going to jump in and just comment on that real quick in that I'm an internist by training, but I call myself very proudly a long COVID doctor. And I have a lot of patients who have ME/CFS without a COVID infection as well. But we're kind of jumping in together. I was a primary care doctor beforehand, and looking up the data in primary care, like there's something like 45% of primary care doctors and clinicians are burned out. And that comes from so many things. It comes from the model we have in medicine. Hey, you get 10, 15, 20 minutes with a patient. You have to do this. You need to diagnose something, have a report with the patient, send off the medicine, document. It's a lot. And then bam, move on. And then you fight the insurance company that you didn't code something correctly or a lab isn't covered. There was a study, I think, out of the National Institute of Medicine, or I think they changed their name. For every 1 hour of medicine I practice, I do 2 hours of paperwork. So it's just this idea of when a patient's coming in as a doctor, I want to figure out medically what's going on, support them and make an answer. And I might not necessarily be really documenting, hey, Tim today, he's able to walk 5 minutes. I had a patient yesterday who said, hey, Dr. Malcolm, I'm getting better. I was able to walk 5 minutes for the first time in 2 years. And I'm so wrapped up, as a long COVID doctor, as rare as I am now, I'm so wrapped up being like, okay, what's the pathophysiology? What's the next medicine? That I might not jump in and make that documentation. So exactly what Dr. Jackson's saying is, if you are being an advocate for yourself, being like, hey, can you make sure you're writing that down? Please write that down. And one of the problems with that is the doctor's like, hey, I'm burnt out already. I'm trying to figure this out. I have no idea what long COVID is. Okay, fine. I advocate for my patients, go see your primary care doctor frequently. And sometimes they're going to say, I have no idea what long COVID is. It's all in your head, or it's too complicated. I'm not touching it. Fine. Use them to go and say, hey, I'm actually going to show up once a month, once every 2 months, and I'm just going to document to you and make a legal trail of what's going on here. Okay. Because that's really what you need. Because what I'll tell my patients is, I need you to have money to run some of these tests. Like, I hate to say it, like I do. There are tests out there that are developed by private companies where we're looking, people are looking at this marker, that marker, people read papers. Hey, let's go off and develop that. It's not going to be available by your insurance company right away. They don't want to pay for it because it's not acceptable yet. So I need you to have disability. I need you to save your money where you can. And so creating that paper trail is important, even though it's so disappointing as a patient to be like, my doctor's not doing anything for me. They're not trying. At least tick that box off is what I really want to advocate for.
Thank you for sharing that. Ty, you got your hand raised. What would you like to share?
Yeah, thank you. I mean, first off, we could probably run this thing 3 hours because I'm seeing 3 hours worth of questions. But Michelle posted a question that I think points to the elephant in the room, and that there's a socio, and not talking about her, but in the long COVID patient disability journey, there's a socioeconomic cruelty to this, in that me, for one, I probably had close to 300 doctor appointments and tens of thousands of dollars spent for me trying to get well. But as a byproduct, I had Rhythm and Mayo Clinic saying, this guy is sick, he can't work. Short of that, I mean, there is a function, not necessarily in every hospital, but they certainly had one at Mayo, and even locally at the hospital that's dealing with my neuropathy and cancer, they've got something known as a doctor of occupational medicine. And that might be someone within your medical system that is expert in filling out disability paperwork. Because your family medicine doctor, although that my family medicine doctor filled out my very first one, they may not know what long COVID is. They may not understand how to fill out the answers accurately to get you the best possible outcome it is, I acknowledge it's a complex journey. But that's why I'm passionate about the people on this call today. So I don't know specifically with Michelle's question. She says, like, I don't understand. My doctor says I have long COVID. I can't work as a police officer, but how do I prove that without tests that show that? So I don't know if we want to refer that back to Malcolm or Jackson, Dr. Malcolm or Dr. Jackson, because that's a great question.
It is a great question. And Michelle, if the issue is cognitive in nature, there are tests, some better than others, but there are tests that are sensitive to even subtle decrements in cognition. And if that's the problem, let's have a one-off conversation. Just reach out to me and I'm glad to provide an opinion about what tests those are. This is challenging, no doubt. It's challenging. And I think the economic dynamic that that Ty referenced is true. This is a phenomenon where the rich get richer and the poor get poorer, as it were. That is, people who are well resourced still struggle, no doubt, but often they are relatively more able to pursue experimental therapies and things of that sort. People who were already living on the edge have found often that long COVID symptoms have literally pushed them out of their apartment, into their car, where they sleep or couch surf at a friend's, if you will. So their economic reality is, I'm not a paid spokesman for pandemic patients, but I would say that's partly why the work they do is so important, because I think it levels the playing field a lot and gives access to legal resources that others typically wouldn't have. There's an economic disparity, to be sure, that affects how we can pursue healthcare and legal aid as well. And it's unfortunate, and it's a reality.
Absolutely. Well, thank you for being our spokesperson for a few moments there. I really appreciate that. Vicky, I'm curious if you have any ideas on how legal and medical professionals can collaborate most effectively through these types of situations.
Absolutely. I think, well, first of all, it's an incredibly important relationship when you're dealing with someone who's disabled and, trying to get reasonable accommodations or trying to get leave from their employer, that the advocate be able to first guide their clients and your patients I always tell my clients to please keep a log so that when you go into your doctor, that doctor can give you the specific information that both Dr. Jackson and Dr. Malcolm have been saying needs to be in their records. So I encourage them to write everything down that they're saying to me. I can't think, I can't function, I can't look at a computer for more than 45 minutes at a time. All of these things are incredibly important details that they might remember in the moment that they're speaking to me, that I ask them to keep notes of so that they go to their doctor and they get that specific information. Once they have a medical provider and they have an idea of what it is that they need, that medical provider and the attorney can work together to try and obtain that, whether it be a reasonable accommodation, a period of time that's leave, and or if they're at the stage where they need to actually work on trying to get disability benefits, whether it's through a private insurer or Social Security disability, then we can work together to try and make sure that the forms are completed correctly. And when I say correctly, it's in a way that's going to allow them to achieve the goal that they're trying to achieve, whichever version that is. And then if it's not, make some adjustments to the records or the forms, but work together to be able to do that. I've always said from the perspective of a nonprofit lawyer or civil rights lawyer, having medical, legal, collaborative relationships is the best benefit to individuals who are facing significant difficulties. And so I'd really like to see a day when we have at long COVID clinics also, legal staff that can be there to assist.
Absolutely. That's definitely something we're working towards and really eager to do more of that work. We had a question in the chat for Dr. Jackson. Could you name some of the specific cognitive tests that might be helpful for patients?
Sure. And I would make this comment too. You know, there is cognitive assessment, and then there's cognitive assessment. And Ty referenced what is relatively more laborious cognitive assessment. He mentioned it was 3 or 4 hours, and often it is. Sometimes it's longer than that. But typically, if we are going to tease out the nuances of cognitive impairment, it cannot be done in a 10-minute test called the MOCA or the MMSE. It typically is done in the context of a much longer battery. So areas where I would want a neuropsychologist to evaluate me if I had long COVID and was interested in trying to identify the presence of problems would have to do primarily, I think, with attention and processing speed and executive functioning. We see some people with memory deficits, but often when we drill down deep, we find that the cognitive problems in people with long COVID are not really about memory. They're fundamentally about attention, and the way they show up is they show up in the form of memory deficits. That's typically what we find. So a good neuropsychologist, and they'd be responsive, I think, if you ask, would be evaluating attention and processing speed, executive functioning in particular. There are literally dozens and dozens of tests in those domains. I think more important than the individual tests probably would be to evaluate those domains, to make sure they evaluate those domains. If someone wants to have a lengthy conversation with me about what those exact tests would be, send me an email. I'm happy to have that conversation. But really what we would be looking at, ideally, I think, is what I would call a gold standard or definitive neuropsychological battery that would be sensitive in identifying even mild cognitive deficits, particularly in areas of attention, executive functioning, and processing speed. That's really what you want.
Absolutely. So Dr. Malcolm, when you think of this more broadly in the field of medicine you practice in, can you think of or share some tests that might be helpful for people?
Yeah, so this is that's kind of what I'm seeing in the chat. So like what tests? And so I think the thing that I need to tell people is a lot of this lives outside of normal or like traditional medicine. So medicine is tradition. And what I mean by that is like in my residency, like I could quote all the famous studies that were, published in all the famous journals, and we all kind of learn. What I talk about is new. There's not that randomized control trial yet, that's going out there that's saying this is what's going on long COVID. The other thing is that long COVID is so many different illnesses, and that's actually probably not the best way to put it. It's all really just a biochemical pathway, in my opinion. So again, I'm expressing my opinion, and someone is going to see long COVID differently than the way that I see it. So for example, like what I do think is that it is a microvascular disease, kind of as one of the first initial hits that occurs. So this is the work of Reza Pretorius down in South Africa, showing that these microclots happen. And so some of the kind of people in the chat are saying like, what do I do when I don't have a doctor or a clinician who's like willing to like try things on me? I had to quit my old job in order to pursue more experimental therapy. And again, the therapy is based on data. It's just not randomized control data quite yet. So in terms of kind of like this microclotting theory, someone kind of put in this, like, what about this paper from 2024 from Zurich? So there was a paper that came out from a lab in Switzerland that said, hey, you can actually look at long COVID and see if your von Willebrand factor is elevated, if you have, reduction in antithrombin 3. One thing I need my patients to understand is there's a difference between a research lab and a commercial lab. And a commercial lab is like you go to your doctor, you're able to get a lab and it shows, yes, definitive, something's going on. I've run a whole bunch of antithrombin 3 on people. It's supposed to be low, but it hasn't really been all that particular low in people. But again, it's low in some people. And is that because the microclotting vascular inflammatory issue that's going on is more prominent in their case and hasn't kind of fixed itself? For example, there was a big paper that came out of the University of Pennsylvania, UCSF, that showed serotonin to be really low. And this is having to do with the gut infections or persistent infections that are happening in the gut. There's mounting evidence that there might be a persistent COVID infection there or other infections. Many different infections live in the gut. And so running a serotonin level. But then when you run a serotonin level, you have to be off caffeine and tea and plums and a whole bunch of stuff for a couple of days. And a lot of my long COVID patients, they don't have the fatigue, they don't have the ability to do that. And then when I run that test, it's not necessarily all that low. And so when I come back to patients being like, it's not that low, is that because it's not going on in you, or is it because the test is not a research grade test? Study out of UCSF showing that there are fungal elements in the blood. And that I think is likely because the immune system is affected. There's great data out of UCSF as well that the immune system is becoming dysfunctional in some patients with long COVID. And so could that activate a persistent fungal infection in the gut or allow that fungal infection to kind of take over? Or was it rather that the gut, leaky gut is now happening and you're having a porousness to the intestines and they're coming through? And so I've run tests on people to look at like, the traditional commercial lab to see if there's fungus in the blood. And of course that was negative, because if everyone had fungus in their blood, they would be really, really, really sick. They'd be dead. So there's lots of tests out there, but what they're showing every time I read a paper is just this idea of like, really, can I look? So I'd say like you can look at the antithrombin 3. You can look at D-dimer. D-dimer is a microclotting, is a test that indicates clotting. A lot of times my patients will come back and say, oh, my doctor saw it. They said it's an inflammation. Look a little deeper, you know. There are a few out there, and I kind of am I'm not certain how much I can say because it's still so uncertain. I present this data to patients and I say, hey, I think this is what's going on. And so I've come to other doctors and I say, look at that test, look how high it is. I don't understand that test. It must be wrong. What you're doing is wrong. But really, so, a D-dimer, something called a thrombin antithrombin could be helpful in some people. An antithrombin 3, a von Willebrand factor, the ratio of ADAM-TS13 to von Willebrand factor was a study that was published back in the United Kingdom in the summer of 2022. That could be helpful to push you in that direction. Something called an organic acid test might push you that there's fungal elements in kind of going on and that you have mitochondrial dysfunction. There's some kind of new age stuff looking at cytokines, looking at microclots. That's an option. So there is a lot out there. And so my recommendation would be 1, to get into your PCP's office, 2, to get into a long COVID clinic. So if you're in California, Stanford, UC Davis, there's lots of them. I'm a little different. I'm kind of at a startup out of California, so I'm a little different. So I'm a little bit more kind of look at data a little bit differently, but use your teams to see what you can do. So that's all I got for now. I know that's disappointing for some people, but there are answers out there. I do say I actually have to go. I have a long COVID patient I have to go take care of right now. So thank you, everyone, but that's kind of my 2 cents.
Thank you so much for sharing all that really valuable information, Dr. Malcolm.
Absolutely.
Thanks for joining today. We really appreciate your perspective. So there's a ton of really great questions in the chat. I wish we had time to answer all of them, but we are going to wrap up. But I have 2 announcements that I'd like to share with everyone before we do that. The first is I'd like to recognize the Moderna Charitable Foundation. They have been a really great sponsor to pandemic patients, and they are the philanthropic arm of Moderna. And they support organizations and causes that promote public health and access to quality healthcare, advancing scientific education and innovation, and advocating for diversity and inclusion, particularly in underserved populations. They have been a tremendous partner to pandemic patients, and they have a number of people from their staff joining us for today's webinar. So I just want to give you all a shout out and a thank you. And then my second announcement is that if you've been following our work, you may know that one of our most impactful programs has been the Pandemic Legal Assistance Network. And through this program, we have delivered pro bono legal assistance to countless Americans experiencing issues related to COVID-19 and disability. I'm very pleased to share that our program has entered a new phase through the incorporation of Pandemic Legal, which is a law firm that provides free and reduced cost legal services to Americans affected by the coronavirus pandemic. By establishing Pandemic Legal as its own law firm, we are able to offer the full scope of legal representation to Americans affected by COVID-19. We are extremely excited to reach new heights in our mission of providing support and services to people affected by COVID-19. And to learn more about Pandemic Legal or to get help with your legal issues related to COVID-19 and long COVID, I invite you to visit our website at pandemiclegal.org. So that is it for our presentation today. Thank you everyone for joining with your great questions. I hope this was some valuable information for you all. Thank you to our panelists for sharing their perspectives, and happy International Long COVID Awareness Day to everyone. So thank you again, and I hope you enjoy the rest of your day.
Thank you. Bye all.